In the interest of time, maybe what it will do is we'll just get rolling with some of the pre-webinar comments. So I want to thank all of you for actually joining Friends of Medicare today. We're very, very thrilled to be able to have the guests that we have with us today, our panelists. We're not very thrilled about the subject area that we're going to be talking about. I think this is one of those things that we didn't ever want to see in Alberta again after what we went through with Bill 11 in the 1990s and Ralph Klein. But just again, thank you so much for joining us. First of all, I would like to welcome you on behalf of Friends of Medicare. Friends of Medicare is an organization that has been for the last 40 years promoting the protection and expansion of our public health care. And that's something that we have been fighting for decades now, is this constant rebirth, if anything, of privatizers and those that see the opportunity or see Alberta as a profitable and ground for the possibility of making profits from the poor health of others. So for us, this bill that we're going to be talking about is very concerning in our history, in our political history. And we want to make sure that all of you are aware of some of the implications of this bill and what we can do to move forward. We have a government who has a majority and is able to pass this type of legislation. Unfortunately, we're in a situation where that was not able to be mitigated at all in the manner that in which it was passed. And so I think it's a good opportunity for us to hear from experts, from frontline workers, as to how this bill is going to impact you, how it's going to impact me, how it's going to impact our families and our community and our society as a whole. So again, for those that just rolled in, thank you for joining us. I just want to do a bit of housekeeping. The format of this evening's webinar is going to be, we will have each of the panelists make a presentation. And I encourage you, if you're like me and you forget things, to put your questions in the question and answer icon that's at the bottom of the Zoom screen. And what we will do at the end of the presentations is we'll go directly into the questions and try and answer as many as we can. In the event that we don't get to your question, don't worry, because what we can do is forward those questions if they're specifically for each of the panelists. We can forward those questions and then they can answer them for you. As well, at the end of this webinar, we will send you, Alyssa, our communications director, will send you a link to this webinar so that you can rewatch it. And if you have any more questions, you can send them to us and we'll do our best to be able to answer any question that you may have. So please do that. And then that way we can maximize the time that we have together tonight to discuss this very important bill. So just to kind of give you or set the stage for this, Bill 30, with Bill 30 and the regulations that will be coming up as a result of this bill, we see how for this government, how far actually this government is willing to go to satisfy their never-ending quest to privatize our healthcare and to hand it over to those individuals and corporations that eagerly anticipate the profit to be made from the poor health of Albertans. Bill 30 provides the legislative framework to do exactly that. It creates a market entry and that will allow private clinics and private surgical facilities to basically be introduced aggressively into our public health care. The changes contained in this bill have the potential to to turn over the resources, our healthcare resources, our healthcare dollars and staff to private companies that will be subsidized directly by the public health dollars. And rather than going into our public system and expanding it and improving it, they have chosen instead to look at private solutions to some of the issues that we see in our healthcare, such as wait times. So for us, it's a very difficult bill to try and navigate. This was an omnibus legislation that was passed in the middle of a pandemic, in the middle of the night, after the government imposed limits to debate, where the opposition, and watching it the other day, it was very heartbreaking. The opposition would introduce amendments. They would be voted down even before they were debated, and it was over and over again. And at the end of the night, in the middle of the night, they just passed this legislation. So this is our reality now. And like I said, we're very, very happy that we have two experts in what the impact of this bill will be on all of us. And I would like to turn over the floor to our first panelist, Dr. Jillian Ratti, who's a family physician and clinical lecturer with the Department of Family Medicine at the University of Calgary. She practices in downtown Calgary at the Sheldon Schumer Health Center and can often be found outside of her lunch hour protesting UCP corruption and austerity. When not totally engrossed in provincial fights to save public health care, she also proudly advocates at the national level as a board member with the Canadian Doctors for Medicare. Dr. Ratti?
Hi, everyone. Thank you so much, Sandra, for that introduction. And I'm really glad to be here again. I had a lot of fun at your last event right before the pandemic. I think it was only a few days before the lockdown, actually. So I'm glad to be back again, but unfortunately it's not in person. I like in person better, but we'll do our best. So yes, like you said, I'm a family doctor. I'm a teacher of students and residents. I'm an activist. I'm a parent. I'm a lifelong Albertan. And I'm a board member for Canadian Doctors for Medicare, and I'm here speaking on behalf of them for the first part. So this little talk that I'm going to do, I'm going to kind of speak with that hat on, and then when the question and answer period comes, I'm going to just take that off and just speak like Jillian, which is mostly the same as Canadian Doctors for Medicare Jillian, but it's slightly different. So for the next 10 minutes or so, I'm going to take a bit of a walk through Bill 30 very briefly. I'm going to leave the technicalities to Dr. Hardcastle, and I'm going to link Bill 30 with the UCP's attack on physicians in this province and the ways that that attack works as part of a strategy of chaos. And that strategy of chaos is meant to undermine the public system and increase the involvement of corporate, private, for-profit delivery of medical services in Alberta. And likely, I mean, I think the end goal is also corporate, private, for-profit funding of medical services. But for the moment with Bill 30, it's mostly focused on private funding for delivery. And kind of before I get into that, I just want to talk a little bit about how this feels very personal to me. It is very, very hard to watch all of this happening as a lifelong Albertan. I saw this happen in the 90s under Klein. I was much younger then, but I saw it and it was awful. And that anybody would want to repeat this and make it even worse is, it boggles my mind. I can't really believe that we're doing this again. This is the worst deja vu that I've experienced, to be honest. It feels like a re-traumatization as someone who's lived here my whole life to see this again and to fight this again. Professionally, it's been also very difficult from a professional perspective because up until 6 months ago, Alberta was definitely seen as the leader in quality of public service across the nation. When I went to a conference in Vancouver 9 months ago, everybody would stop me and ask me, oh, what are you guys doing in Alberta? Can I figure out how to copy what you're doing in Alberta? Oh, primary care networks, what are those? How do I get that going? It sounds like there's really great success with those. So professionally, to see a lot of our amazing successes within a public healthcare system really at major, major risk, it's so disheartening. And, you know, it took us ages to rebuild what Klein tore down. And as soon as we got to a place where we were functioning well, here we are again, and it's just heartbreaking. So, I mean, yeah, so the system was not broken. They are clearly breaking it. Bill 30 and the attacks on physicians, they are breaking the system. And I mean, well, why would you do that? And does the UCP really want to increase private funding or delivery for healthcare? And how do you know that, Dr. Ratti? Well, I mean, I think they've given us plenty of messages that they do indeed have that as their goal, despite the fact that they are constantly saying that they don't, despite the fact that Jason Kenney had a big press conference with a big signature on a public health guarantee during the election. It's very clear that their actions are speaking louder than their words, and that private services are part of what they are trying to push here. This is a party that specifically voted down a resolution at their policy convention that would have required them to abide by the Canada Health Act when making healthcare policy. You know, they also had discussions at that time about clear preferences for allowing private funding and privately administered medical services. The Premier constantly tweets support for private enterprise in healthcare. TELUS Babylon was advertised using a public Twitter account, using public money. And this is a service that is highly problematic. It's making corporations money, but the privacy issues and the quality of care issues are massive. It's pretty clear that this is a government that wants private corporations in charge here. And I mean, just recently, perhaps some of you have seen Andrew Longhurst in Twitter or elsewhere. He's with the Canadian Centre for Policy Alternatives. And a few days ago, he found that a request for proposals had just closed, and that was for advertising for a health contracting secretariat, which is an office whose job is specifically to attract corporations and reduce market barriers to deliver public healthcare services in Alberta. There is specifically going to be a secretariat for the purpose of increasing the involvement of corporations in our Medicare. So they know they can't say this out loud and blatantly tell the world that they would like to make things more private, because they know that that is politically a very bad thing to do. So they are actually just pretty much lying about it. And that really also links with the major democratic problems that we are seeing with the UCP, and a lot of the doublespeak that makes it very hard for the average person to interpret what they are actually going to do. So what we have to do with them is watch what they are doing, not what they are saying, because what they are saying will just confuse the issue. So I will just make a distinction in terms of funding and delivery. I've kind of alluded to it already, but it's important to note that we already do have private delivery of medical services in Canada, and specifically in Alberta even. So your average family doctor's office is actually a privately delivered healthcare service, but it's publicly funded because that physician is billing the government, and there are no fees at the point of accessing medical services, or at least very few. And so that's the part where, from a Canadian Doctors for Medicare's perspective, we are not arguing that we should get rid of that kind of private delivery of healthcare. It has functioned relatively well for us, and unless there is evidence that shows that it's not going to function well, that is not the argument that we make. We don't argue for fully publicly delivered services. But where we do start to take some criticism is when you start seeing, as we do in Bill 30, the addition of corporations and private, corporate, investor-owned, for-profit healthcare services. Because when you look at that particular subset of private delivery, your outcomes and your quality of care go down significantly. So when your goal as an organization is to ensure equitable, high quality access, it just doesn't meet the bar. And Bill 30 introduces exactly that. And it's unprecedented in Canada. You don't find that anywhere else. And it's unprecedented in Alberta. So essentially what it does is allow corporations to bill the government directly for health services. Currently, it's only physicians who can, for the most part, there's a few exceptions, but the vast majority, it's physicians billing the government directly for medical services. This allows corporations to bill the government for services with the idea, when you look at it from a physician perspective, that it seems like the government would prefer that physicians are employees of corporations rather than billers of the government. So, I mean, when you're looking at Bill 30, it has a lot of nice language that seems to support the Canada Health Act. But if you actually look at its implications and you see how it's setting the stage, it looks very clear that there's definitely an increased role for private delivery of healthcare services, and you can certainly see how it's setting a stage for private funding. And the reason for that is, I mean, if you've got corporations who are not bound ethically as physicians are, running clinics and surgical centers, their main goal is profit. Their main goal is not the ethical practice of medicine. So, you know, they are wanting to increase profits. And one of the ways that they can do that is by charging privately as well for the same services that they're billing the government for publicly. So I think it's pretty clear that once corporations get a foothold in here by billing publicly for medical services, that the next easy step for them is to say, okay, well, now we would like to privately bill and directly bill patients for these same services in addition to billing the government for these services. So really you're creating, it's very much opening the door for a two-tiered system that is not equitable and that is likely not high quality either. Now, yeah, and I guess the last point I'll just make quickly there is that corporations often, in terms of their quality, they often skim the easy stuff off the top. Private surgical facilities, specifically in Australia, when they allowed for this kind of a scenario, the private facilities take all the easy stuff and the public system is left with all the hard stuff. And in addition to that, physicians often want to work in the private system now because it's easier work. And so the public system struggles to get the physicians to do the work. And it also has the more complex cases, which are harder to manage. So public wait times can actually go up in this kind of a scenario. The government is constantly talking about how this is going to decrease wait times, but if they can conjure up extra doctors during a pandemic that is global, good luck to them. They're not going to be able to do that. This is not about decreasing wait times. This is about corporatizing healthcare. So I'm just going to link that quickly. Hopefully you'll give me a time warning, Sandra. I'm still talking, but I'm going to link this quickly before I finish with the specific attacks on physicians, because really it comes as a package. Bill 30 and attacking physicians is part of the chaos package that creates the conditions to undermine public health care and create a private system. So, I mean, certainly there's individual attacks from the government against individual physicians, and I've been part of that whole scenario. I know very well what it's like when the government decides that individual physicians deserve censure and deserve attack online and comments from the legislature, etc. And that's, again, linking with a really troubling pattern of anti-democratic behavior and authoritarian behavior. And I'm certainly not the only physician. There's also a physician who had the health minister show up in his driveway and yell at him. And multiple others who have had various government representatives, attacking them on Twitter or in person or through various channels. And it's really quite troubling. And then, of course, there's attacks against our collective and the Alberta Medical Association. If you're not aware, the Alberta Medical Association is our professional body, so it advocates on behalf of the profession. It's not a union per se. We can't strike as physicians, but it's similar to one. It's a labor type organization, and their dealings with us have been wholly abusive, and that's not an understatement to use the word abusive. We were meant to start negotiations for renewing our master agreement with the government in fall, kind of around fall 2019. And right from the beginning, there was no good faith bargaining. They were making offers to us in the media and not bothering to come to us with those things through the right channels. And that just went very poorly. There was kind of odd stalling and odd media type negotiations for a couple of months. And then finally, in early 2020, they just ripped up our agreement completely, said, oh, doctors aren't being serious in their negotiations. They don't really want to cut the physician service budget. And so we're just going to rip up this agreement. And here's the new one. We're just going to impose this one upon you. Now, those of you from a labor background are likely rightfully horrified to hear this, because we all know they're coming next for you. And that's really, again, one of the many democratic problems we've got with this government. So essentially, they ripped up our master agreement, imposed a new framework where they cut specifically family medicine. They gutted family medicine in the middle of a pandemic. They cut family medicine's income, the ability to bill, by about 30 to 40%, depending on what kind of practice you have. And most family physicians pay 30 to 40% in overhead. So essentially, you have a situation here where family doctors, it would not be uncommon for family doctors to have worked for free or close to free during the pandemic in order to keep their offices open. And I mean, come on, that is unbelievably irresponsible. All in the name of privatizing a system. You're going to completely take away the supports you need to deal with a global pandemic. It just boggles the mind. It's completely irresponsible. Fine, you don't like doctors, you want us to make less, fine. We actually wanted to make less. We said we should take 5% less. But this isn't about money. This is about creating chaos in the system. It's about undermining public health care. It's about paving the way for further privatization. So, you know, and rural docs, oh my goodness, you know, they just, a lot of them are trying to leave. A lot of them are trying to withdraw their services. They've given their 90 days notice, which is typical and important. But, you know, AHS decided that they needed them to stay and said, we're still going to schedule you, even though you've given the requisite 90 days notice to leave. I'm sorry, but you need to stay because there's no replacements for you. And we will report you to the College of Physicians and Surgeons if you don't come for your scheduled shifts as they are here. Thank you very much. So the physicians in Pincher Creek are really, really at odds with the government and with Alberta Health Services right now. I mean, I also want to briefly mention the strong arming of this government with the College of Physicians and Surgeons of Alberta. So the College of Physicians and Surgeons of Alberta is our regulatory body. It's the body that gives me my license to practice medicine. It's the body that makes sure that I'm practicing appropriately and within standards that are appropriate according to my peers. So Bill 30 also increases the number of public members on CPSA Council, which is kind of the governing board, if you will. And in theory, that actually sounds like a good idea to me. Under any other government, I would say, excellent, go for it. We should absolutely have more public oversight of physician behavior and physician practice. But what I think is going to happen here is this will be a political appointment of people who are conservative donors or conservative supporters, and who are going to go onto that council and undermine the entire council and say, oh, whoops, this whole thing really shouldn't exist. It's so corrupt and mismanaged. We're just going to have to get rid of this whole thing altogether. And, you know, under any other government, we could have a discussion about physician involvement. With this government, it seems very clear that they just want to undermine all of the collective physician voices that we have in Alberta, because they know that ours are the loudest in favor of public health care, and we are the people who stand in the way of them corporatizing our healthcare. So they're really not. They are not being timid. They're doing everything that they think they can get away with to just take away our collective voice in defense of public health care. So, you know, I guess I better wrap up. I've been talking too long. And I'll leave some more of my talk for the questions. But thank you everybody for being here. I think this is a dark time, and I look forward to your questions and also to Dr. Hardcastle's presentation. Thanks.
Thank you, Dr. Ratti. I think she's a perfect example why it is that this government's trying so hard to silence anybody who opposes their plans. I'm not too sure she mentioned, but I don't think so. I mean, the AMA, in a remarkable turnout, and the survey that they had, 98% of those that voted basically indicated that they have no confidence in this minister. And for us, that's a huge issue. And this government better pay attention in that you can't build or try to implement any type of good health policy when you don't have the trust of those that provide services or the rest of us. And so I think it's going to be a summer of hopefully of looking inward for this government to kind of see how they can repair some of the damage that they have done in the relationship with physicians in this province, and what will undoubtedly be the relationship that they will have with the rest of the public healthcare workers, hopefully coming out of this pandemic soon, but it's not looking like it. But our next presenter, and somebody that we're very fortunate to have, is Dr. Lorian Hardcastle. She's an associate professor in the Faculty of Law and Department of Community Health Sciences in the Cummings School of Medicine at the University of Calgary. She is also a member of the One Health Consortium, O'Brien Institute for Public Health, and Conjoined Health Research Ethics Board at the University of Calgary. Dr. Hardcastle's research interests include the regulation and governance of healthcare delivery, liability and accountability of health facilities and government, public health law and policy, and self-regulation of health professionals. Thank you for being with us tonight.
Thank you for having me. Can everyone hear okay? I assume I unmuted, so hopefully you can all hear. So what I wanted to do is to just take you through Bill 30 in some detail. Bill 30 amends many pieces of legislation, but I'll take you through some of the key aspects of Bill 30 and some of the policy concerns that it raises. And so I'm going to hit on four main things that Bill 30 does, some of which you've heard a bit about already. The first is that Bill 30, currently, if you go to see your doctor generally through their professional corporation, will bill the government for the health services that he or she provides you. One of the big things that Bill 30 does, just to reemphasize this point, is that it allows other kinds of corporations. And so these could be large corporations with shareholders. These are not professional corporations run by doctors. This is any kind of corporation, and will now be able to bill the government for healthcare services. And so you will hear the UCP talk about, we already have corporations billing the government for healthcare services. They are talking about professional corporations, which are doctor-run corporations that have to abide by the college's standards and those sorts of things. These are corporations. This could be Kaiser, this could be TELUS. Any kind of corporation will now be able to bill the government for health services, and then those corporations will be able to contract with doctors to say, come and work at their surgical facility or come and work at their family doctor clinic. And so this raises, the main concern that this raises is, well, two concerns are with quality and cost. And these things are interrelated because these corporations have to realize a profit somewhere. And so that profit is either going to be realized by delivering lower quality services. And we see this, for example, with the private for-profit long-term care homes, where they tend to deliver lower quality services than the not-for-profit long-term care homes. And the reason for that is because they're doing things like having fewer staffing hours or hiring lower qualified staff in order to carve out a profit. And so one of the concerns with the involvement of corporations is that quality of care issue. And evidence from the US, evidence from Europe, evidence from Canadian long-term care homes generally tends to show that there are these quality problems where you have for-profit entities. The second concern with involving corporations is a cost problem. And so whenever you have a corporation contracting with government, for example, to provide health services, they will negotiate into that contract a profit margin for themselves. And so even though we tend to hear this language around the private sector with them being more efficient or less bureaucratic or more streamlined or those kinds of words, again, the international evidence tends to show that because those private for-profit companies need to make a profit, they tend to cost more than their counterparts in the public system. And so again, you'll hear the government here say, well, your family doctor is a corporation and they're trying to make a profit. And I would suggest that, you know, what we're talking about there is the difference between basically a small business that's paying itself a salary versus a corporation that has to pay dividends to its shareholders. And corporations actually have a legal obligation to advance the interests of their shareholders and to maximize profits in favor of their shareholders. So that's the first big change is what I've called the corporatization of health delivery. The second major change is that the legislation will facilitate sending out up to 30%, that's the government's target, of surgeries to private facilities, which are called chartered surgical facilities. And so currently there is some of this. Many people who get cataract surgeries will have those done in an ophthalmology clinic outside of a public hospital. So there is already some of this, and there are concerns with it. For example, it's very common for the private ophthalmology facilities to upsell you to what are called enhanced medical goods or services, and so patients will pay extra for those. And some patients report feeling pressured to buy those goods. And so what we're going to do, and so again, the rhetoric that you'll hear is, well, under the NDP, services are already going to the private system. Surgeries are going to the private system. And it is true that some are, but what we're talking about here is doubling the number of surgeries in the private system, significantly increasing the kinds of surgeries that are done in the private system. Right now, we're talking about a quick cataract surgery under sedation being done in the private system. They're talking about much more significant surgeries being done in private surgical facilities. Mastectomies, hernias, joint operations, all sorts of procedures. And so to get to that 30%, that really is a significant number of services. And so all of these services are going to be publicly paid for. And so the government will tell you that this is no problem because these are publicly paid for, so you shouldn't worry about this. I worry about it for three reasons. Again, the quality problem of these private surgical facilities, they have to make a profit, and so that profit can sometimes be made by delivering lower quality care. The second concern that I have is cost. These facilities will negotiate with the government to get the best deal that they can. And where we've had private surgical facilities in the past, there was a orthopedic hospital in Calgary. They ended up being paid more to do the simple, easy cases than was being paid in the public system to take the more difficult cases. And so they were making about $500 more on average to do simple cases than it was costing in the public system to do the more complex cases. And that's because they needed to make a profit. The other thing that we'll tend to see is you end up seeing public subsidies of that private system. And so, for example, when that facility ran into financial trouble, that orthopedic hospital in Calgary, the public system ended up bailing them out, or attempting to bail them out. They ultimately failed. We're already seeing the public funds go into privatization in terms of the health contracting secretariat that you heard about earlier. The government is already infusing public funds into this secretariat that will attempt to deliver private services. The other issue is that currently under the legislation, you can only have surgeries in a private surgical facility if they have a 12-hour or less stay. So for overnight surgeries or those sorts of things, the legislation doesn't yet enable that to be done in private facilities. But the concern is that any complications that arise with cases or anybody who has to stay longer than that 12 hours, they'll be sent to the public system, and again, we'll end up subsidizing those private profits. So So we see the corporatization piece, the private delivery piece. The third piece of the legislation that you've already heard about is, so I won't say much about it, is upping the number of public representatives to the college. And one of the reasons I think that is because the college is potentially an entity that can act as a barrier to some of this, because all of these chartered surgical facilities have to be accredited by the college. And so potentially one of the government strategies may be to once they have more people that they've appointed to the college, to make it easier to get that accreditation. So that's a concern. And then the fourth change that I wanted to mention with the legislation is, and this is very similar to what's happening with the college, is Alberta has a health quality council. The Health Quality Council is responsible for looking at outcomes in the healthcare system, generating evidence, and they're arm's length of government, with the idea being that they're this independent body that can act as a check on government and evaluate government, and where needed, sometimes suggest to government that they should be doing something different. One of the concerns in Bill 30 is that it will significantly erode the independence of the Health Quality Council. It turns it from an arm's length body that reports directly to the Legislative Assembly, and basically turns it into an entity that reports directly to the Minister of Health. The Deputy Minister of Health has the right to attend Health Quality Council board meetings. The government can issue directives to the Quality Council. And so the concern is that this may have been an entity that may have generated evidence showing that some of what the government is doing is not evidence-based. And so if we take away their independence to say that, then we potentially take away that voice of opposition. And so those are the highlights of Bill 30. And again, what Bill 30 really does is it doesn't take us to private finance, private health insurance. It's really about private delivery. Private delivery is often painted as innocuous, but I've highlighted some of the ways that the profit motive can make private delivery not that innocuous. The other thing, though, is that this may very well be a stepping stone to private funding or private insurance, which is the notion of a two-tier system where you can actually buy quicker access to care. And so the reason that I call this a stepping stone is because of some of the other background facts. We have the Fair Deal Panel report where it suggested that the Canada Health Act may be sort of a bad deal for Canada or for Alberta, and that maybe we may decide, because the view of the panel was that it stands in the way of innovation, which is a code for privatization usually. And so one of the concerns is that we may just opt out of the federal money that comes from the Canada Health Act, and Alberta could do that. Alberta could say, keep your 5-ish% of our healthcare budget, federal government, and if they did that, then that could open us up to private insurance for publicly insured services. It could open us up to people just being able to pay out of pocket to get access to services that are in the public system. And so there is this risk that the government could elect to opt out, in which case we could see this two-tier system develop. And so those are some of the concerns with the two-tiered piece. And the government will say over and over again, this isn't two-tier care, and it isn't yet. But it certainly sets the stage that's where we may be going. And I think that as we see private companies start to become involved in the delivery of healthcare services in Alberta, and with them come lobbying firms, and with them come potentially bigger private corporations, especially if other provinces open up to privatization. We could see some actually major US hospital chains want to come to Canada. And once those big companies are entrenched in Alberta, they will lobby for private insurance, for private finance. So private insurance, out-of-pocket payments. And I think this is a government that would be receptive to being pushed in that direction. So maybe I'll let us go to questions, just because I see there's lots coming in, but I'm happy to elaborate on any of those points during the questions.
Thank you so much to both of you for these great presentations. And you're right, we have quite a few questions. And like I said before, if your answer is not necessarily answered, we could for sure send you, let us know who you want the answer from, and we'll do our best to try and answer all the questions that people have sent. I have one question here that will hopefully start the conversation. And it says, what will be the overall impact, be surgical wait times if resources and staff over to private facilities? Minister Chandro stated on CBC radio recently in an interview on Radioactive that, for example, the Peter Lougheed Hospital had 17 surgical suites operating and 2 running 24 hours. How is this bill supposed to help the system better if they are transferring resources to private delivery operators?
I can take a stab at that, maybe. So I think that we hear a lot of rhetoric from the government saying that these private delivery will shorten wait times in the public system. In order to shorten wait times in the public system, we need 2 ingredients. We need space and we need people. You need more space and more people if you're going to shorten public wait lists. The concern with the private system, and as you've identified, there is actually spare capacity in the public system. We don't run public operating rooms 24 hours a day, and so there actually is capacity that exists in the public system to shorten wait lists. And there's other strategies other than money as well that we can employ to shorten wait lists. The concern with the private system is, I don't doubt that they will be able to fulfill that space ingredient without greatly affecting the public system, apart from maybe some financial subsidies. I don't doubt that they can build private hospitals or retrofit existing facilities to become private hospitals. The problem to me comes with the health professionals. And so you have to find people to work at these private facilities. And the concern is that, yeah, are there health professionals that could work 5% more, maybe 10% more, moonlight at these facilities without working any less in the public system? Yes. Is there enough of that excess capacity to do 30% of the surgeries in the private system without affecting the public system? The answer is no. There are not that many surgeons in Alberta working, and anesthesiologists and nurses that have so much spare capacity in their workday that they can do that 30% without affecting the public system. And so what we'll start to see is health professionals that will get attracted over to the private system, and the cases that get treated in the private system tend to be the people who are healthier and have less complex needs. And so what you could end up seeing is that, you know, somebody who tore their knee ligament running and who's not really suffering but wants it fixed, they're an easy case. They might get treated right away. Meanwhile, somebody who has severely fractured their ankle, and maybe they're elderly and have comorbidities, so they're not suitable for the private system, that person who really needs surgery and is in great amount of pain could end up waiting longer if surgeons and anesthesiologists and nurses are all working most of their time in the private system. So that's the concern that I have. I don't know if you guys have anything to add there.
Yeah, I think the only thing I would add is that the health minister's constantly saying, don't worry about the number of health professionals, it's no problem. It's very frustrating to watch him say that because it's clearly untrue. He's kind of assuming that physicians will come to work here, or maybe he knows that they won't and he just doesn't care because, again, chaos, destroy the system, privatize. But Alberta is now known across the country as the least desirable place to work in Canada for health professionals. And there's frankly no way that Canadian doctors will move here.
Yeah. Thank you for those answers. I have quite a few questions that actually refer to the same thing in terms of how these changes impact or go against the intent of the Canada Health Act. And we have one that says, are these changes not against the Canada Health Act? Medical care should be free at the point of access. Doesn't this go against having private surgical clinics?
I can, unless you want to go first, Dr. Ratti, I can jump in. I guess, well, it's legislation, so I may as well. So on its face, these things actually aren't really problematic from the perspective of the Canada Health Act. I think when you start talking about the spirit of the Canada Health Act, I think that yeah, and perhaps ethically, in terms of how we as Canadians value it, it may. But in terms of the letter of the law, I think the government has been very careful here to draw this line between private delivery that the public system is paying for, and so we're all still covered, it's all publicly paid for. And I think they've drawn a very careful line, because that does sound compliant with the Canada Health Act. And where we get into concerns, though, is some of these concerns with healthier patients getting treated sooner, less complex patients treated sooner. And so you do have these concerns that I think are against the spirit of the Canada Health Act. But in terms of the letter of the law, which is care is free at the point of service, it still is. Doctors can't bill you more beyond what they're paid for by the public system to treat you. They can't. They can try and upsell you to enhanced services, but they can't charge you for insured services. So I think they've been very careful to comply with the Canada Health Act, to see what happens. And then if this works out to their liking and there's lots of opportunity for private investors, at that point, I think we may see them say, forget your money, federal government, forget the Canada Health Act. We can do as we want.
Yeah, and I mean, that's hugely anti-democratic, because Albertans have not voted for that at all. There's this huge agenda towards all of this. I very much think this is where we're headed in terms of pulling out of the Canada Health Act altogether, et cetera. And they, like I mentioned earlier in my presentation, they know they can't say this out loud. So they're doing it in a very devious way. And what was shocking to me when I read the legislation, I'm certainly no lawyer, but when I read it, it makes every effort to say we're in compliance with the Canada Health Act. Like every second line, it felt like they were saying that. But the actual intent of what's happening is clearly not in line with that.
And I have to agree with both of our panelists, because this bill actually creates quite a few gray areas that are open for legal interpretation. So for those of us who follow the work that Friends of Medicare is trying to do around this issue, we are in the process of getting a legal opinion around some of the violations or perceived violations or even violations of the Canada Health Act, most specifically around the issues of payment relationships with the physicians. And I think Dr. Hardcastle talked about that, how this bill will allow corporations to employ physicians. And if you follow Minister Chandra, he was very public about the fact that he's trying to, basically make public how much doctors are billing the province as a way of shaming them, apparently. But what our question has been all along, are you going to be doing the same thing for these corporations? But hey, in Alberta, that always goes under a commercial confidentiality, so we have no oversight about any of these contracts that are going to be offered under these requests for proposals to these for-profit companies. So two things: we have a government who says that they're following the intent of the Canada Health Act, to which we say, no, you're not. Secondly, you're talking about being fiscally responsible and cutting down the cost of what they describe as an unsustainable healthcare system, yet they're bringing in contracts that Albertans will not have access to. We're not going to be able to see the business case behind any of these contracts that they're putting out. They've talked about, the Ernst & Young report talked about $669 million needed to be put into this private Alberta Surgical Initiative. We already know that $400 million has been offered during this pandemic. And 100 million more. So how much more are we actually going to be putting into our healthcare system without actually any accountability as to how that money is being spent? And is it being spent to improve wait times and patient outcomes? Because behind every health policy, there's real people that will be impacted. So I'll get off my soapbox after that one. And there's a question that says, there's a backstop with this provincial bill, right? Vis-a-vis the federal government and the principles of the Canada Health Act. So what are we facing there? I guess that goes with what we were talking about. Just hold on. There's quite a few questions that are, what are some of the implications for rural medical services that you're seeing from this bill? I think Dr. Ratti talked a little bit about that, but if you can expand.
Yeah, so essentially, rural physicians are almost all family doctors. And so their practice is hugely different from mine. I'm an urban family doctor, so their practice is hugely different from mine. They work in hospital, long-term care, clinic. They're kind of all over the place. They work very long hours, and they relied heavily upon time modifiers for their clinic work. And also they see so many patients in a day that when the government implemented a patient cap, like a billing cap, essentially you can only bill for so many patients in a day. That was going to affect their billings to the point where it was no longer viable for them mostly to work in hospital rurally. The clinic was sort of barely, vaguely viable after the government walked back some of the time modifier changes based on a threatened revolt by a few backbench MLAs. So they are in a very precarious position rurally because their hospitals really are not going to be staffed well with physicians, if at all. So their rural physicians don't really know what to do with themselves. They're saying, okay, well, this is my home, this is my community. I'll stay here and work my clinic as best as I can, even though it's even harder for me to make this financially viable now. But they're also saying, but I can't do the hospital work I was doing before, but my community really, I mean, they depend upon it, but I can't do it anymore. So I really feel for my rural colleagues. They've been put in a horrible position. And like I mentioned, from the Pincher Creek perspective, they've just been treated horribly. And, you know, as a group, they just said, look, I can't afford to work in the hospital anymore. So I'm giving you my 90 days notice AHS, and I'm leaving the hospital. Unless we can work something out. And they had a very bad experience with that, where the AHS was threatening to report them to the college. And so it's shocking, some of the stuff that's happening rurally. And rural Albertans should be some of the most angry people when it comes to the way that the government has handled the health file.
Thank you for that. I think this is a really good question that kind of opens up the area of insured versus uninsured services and how they co-play in private for-profit or public facilities where these services are provided. So will there be any changes to which services are covered? I know that Dr. Hardcastle had mentioned some of this, the insured versus uninsured. Can you kind of explain also how that's decided and who decides what's insured and not uninsured?
Yeah, so generally speaking, I mean, obviously in Canada, the Canada Health Act and what provinces focus on is payment for physician and hospital services. And so there's a whole bunch of other kinds of health services that we're really not focused so much on here. But as between hospital and physician services, many things are insured, but of course certain kinds of surgical procedures or certain kinds of other services aren't insured. You know, the obvious example is cosmetic surgery, and that's largely because the Canada Health Act uses the language of providing medically necessary services. And so the government has its list of medically necessary services. But one of the things that they can do is that they can delist services from that list, and then those services become uninsured and are then fair game for the private system to pick up. And so that's actually one way that governments move towards more private finance without actually violating the Canada Health Act. Is what they do is they say, well, this isn't medically necessary, so we're not covering it anymore. And then if you need it, you then end up having to pay for it. And so there actually is a list circulating of a number of health services that the government is talking about delisting from that public insurance plan. And these include things like carpal tunnel surgery. It includes tubal ligation, which has huge sort of gender elements to it, because vasectomy remains on the list of insured services. And so they are looking at changing that list of what's covered, and they can certainly do that. And then the other kind of uninsured service that I talked about was these enhanced medical goods. And what these are, the quintessential example that came up when these kinds of services were invented were foldable cataracts. And so this is kind of an old example, but it makes the point. It used to be that the rigid cataracts were insured by the government, but if you wanted the kind that folded up and so the incision is smaller, the surgery has less risks with it, you had to pay extra to get that. And so these private facilities will be able to upsell people to these enhanced goods. So goods that aren't covered by the public system, but that people, for a variety of reasons, may want. And so that's two things we may see in the coming months is, as these facilities open, we'll start to see the kinds of enhanced goods people are being sold. And I think the last year for which there's data is 2016. But in that year, I think there was about $2 million of enhanced goods sold by ophthalmologists to Albertans. And then we may see delisting. And I'm sure that the private facilities like things to be delisted, because once they're delisted, they can charge the market rate for them. They don't have to charge, they don't have to get paid what they would get paid under the public plan. So those are some of the issues right now between insured and uninsured.
Thank you for that. Do you have anything to add, Dr. Ratti?
Just that I think there were some recent delistings. I can't actually remember all of them, but one of the major ones was seniors drivers medicals. And
Yeah.
I mean, that's a big hit for anybody over the age of 75 who hopes to keep their driver's license.
Right. Thank you. One question that actually can be wrapped up in the role that we're seeing, for example, TELUS Health, have in our province, or even just telemedicine across the country, and all these third-party platforms that are trying to pretend they're doctors online. And one of the questions that we have is, can private corporations sell your personal data, any data, not necessarily just medical data?
Yeah, so there's a huge concern with what exactly TELUS is doing, because TELUS is involved in the electronic medical record. TELUS is now involved in Babylon, and certainly it's profiting off of our medical information, because one of the things that Babylon does is it has a symptom checker that's based on artificial intelligence, feeding your information into it and developing medical recommendations. And pharmacists, there's a TELUS software for them as well. And TELUS is also buying up executive medical clinics. And so TELUS, I think, is really a big player to watch. One of the issues on the privacy front is that we actually don't know entirely what they're up to, because the Alberta government went ahead and implemented Babylon before the Alberta's privacy commissioner had a chance to review the privacy issues. And there certainly are, I've seen the terms of use for TELUS, and there certainly are some privacy red flags with you consenting to your data being sent overseas, and then the country that it ends up in, the governing laws of that country applying. And so there are some concerns, but we don't really know a lot about what they're actually doing. We only know in sort of that terms of use what they could do. And so we really need to hear from the privacy commissioner on this before we let this go any further.
Thank you for that. We have quite a few questions around the same subject area, and those are the people that are asking how will this impact people that are on age or that have disabilities and live on a very fixed income, and they're quite concerned about how changes such as this can impact their ability to get access to health care if they don't have the money.
Yeah, maybe I'll take that one to start. I mean, I guess I'll start by saying it's already difficult when you're on AISH, and the government has just de-indexed AISH to meet basic needs. And I have a fair percentage of my practice is patients on AISH, and I struggle greatly with trying to get what they need in terms of prescriptions that are uncommon, in terms of various devices that they require to live a normal life. It's already very difficult. So my sense is that with increased corporatization of our healthcare system, if you do get a scenario where the healthy people are kind of shunted into a private for-profit type place, we're going to get a situation where the public system is left struggling with even fewer resources to help patients on low income. And so that's one of the many challenges that we're looking at here, and I'm very much not looking forward to that, as I'm sure our listeners are not.
And just to add to that, I mean, we also saw the changes in that doctors would not accept good faith billing at the same time when they cut the funding for, or where seniors needed to pay for their driver's license, right? And that change came into impact in the middle of this pandemic as well, where people were not, I think they extended it for a bit, but it's still on the books there that they're not accepting good faith billing.
Yeah, and that's a good point, Sandra, the good faith billing aspect of things. I mean, a lot of people on the streets, homeless folks, they might not have an Alberta healthcare card for various reasons. And in the past, we were able to access good faith billing in order to get paid as a physician for treating that patient. And they've gotten rid of that completely, meaning, you know, either a physician treats that patient for free or we turn them away. And those are just wholly unacceptable options.
We don't have very much time left, because I want to give our panelists an opportunity to wrap up their thoughts and their presentations. And like I said, we will take these questions and endeavor to answer them as much as we can. We have quite a few questions actually left over, and the chat has been quite busy as well with questions that have been thrown in there. So thank you so much for doing this, but I just want to turn the floor over to you guys so that you can wrap up your thoughts, and then we'll wrap it up with our final comments as well.
Sure, I guess I can go first.
Want to go first? Yeah, sure.
Yeah, is that okay?
Yeah.
I'll go first.
No, go ahead.
So I guess what I see happening is if there's not major protesting, major striking happening, what is going to occur is my physician body, the Alberta Medical Association, will be dissolved. The College of Physicians and Surgeons of Alberta will be dissolved. And we are looking at a situation where the government and corporations are the people who hire and regulate physicians rather than the public and my peers, other physicians. And that has major implications for how the average Albertan is going to access their healthcare. And there are lots of good conversations to be had about physician compensation, and I don't want to make this about physician compensation, because really I feel like the physician compensation issue is just a bellwether issue for public health care and democracy. It's just kind of, it's not, for me, it's very much not about how much I get paid. So I would very much encourage anybody watching to take as much political action as you can around this, because if there is not something major happening in the near future, the steamrolling will just continue. And everything that we have come to build as public health care in this province is going to disappear. And the speed at which this government is moving is phenomenal. And they've still got 3 more years left to play with this public healthcare system that we love. So I just hope that everybody can take to the streets, frankly.
Yeah, I mean, I would really echo those sentiments. I think that You know, the legislation, there's, you know, unlike some pieces of legislation that the government has pushed through, which I think could be the subject of legal challenges, this legislation isn't really problematic on its face, and it's been pushed through. It's law. It's done. And so I think all we can really do is do what we can to push back in terms of its implementation. I think this 30% of surgeries in the public sector by 2023 is so aggressive. We push back against that. We push back against further privatization. You know, we push back against the people that the government tries to nominate to the Quality Council and to the colleges. I think that all we really have is political action at this point. Sometimes there are legal avenues open, but this really isn't one of them. And they have a majority government, so they can continue along as they like. And so I think that all we can really do is demand more of them, and hope that we can wear them down on some of these issues and get them to back off a little bit, and you know, make FOIP requests, see what they're up to, email your MLAs, protests, anything you can do to bring attention to this issue. I think is all we can really do.
Thank you so much for some of those great ideas. I also want to thank our panelists for joining us today. This is a very, very important conversation that I think all Albertans should be having with their families and with their communities and with their co-workers and so forth. For Friends of Medicare, we're also in a situation where this government is trying to steamroll us, and with Bill 32, that will have simply you know, some implications into our existence. So this is a time when we need to pick up this fight, where we need to continue. You know, just being tired of having to fight is not enough anymore. I think one way that we are encouraging people from this province to get engaged, and all the people that participated in this webinar today, we're hoping that you are part of that engaged group now, that you have this information, that you will share this information, and that you will encourage all your people to join Friends of Medicare, because that way you can keep informed of what is happening. We send out all this information on an ongoing basis, and we've had webinars around important issues throughout this pandemic. You know, we've had a very difficult time in trying to get ourselves out onto the street and taking that action as part of our political action. But now it's time that we need to resume the work that we do with our volunteers, and we need to start contacting absolutely everybody, you know, flooding phone lines, flooding fax lines, flooding emails, flooding everything as part of the ongoing action. So right now we're putting together an action package that we'll look at the legalities behind this bill, that will look at some of the grassroots actions that can be taken as soon as possible, and we will be sharing that. But we really encourage you to, you know, to join our emails, to become a member of Friends of Medicare, and to support the work that we do, so that your voices can also be added to the work that we do. It's time to fight. It's not time to give up. They have a majority government, but they also know that Albertans have said over and over again that we do not want private healthcare, and that we know better. Sometimes legality, it doesn't equal morality, and when it comes to accessing public healthcare, that's a moral value that we all have. We all believe in the fact that our healthcare system is an egalitarian system, and we can't allow any government to take that away from us. And so this is a call for action. It's a call for fighting back, and it will be a fall of for sure, a fall full of actions that we must all undertake. So thank you so much for joining us tonight. Again, thank you to our panelists, and I invite you to visit our website, www.friendsofmedicare.org, and find more information right there that you can share with your friends. Thank you again. Have a good night. Thank you for coming.